Good evening, everybody. Welcome to this session on the adrenal. Last class, we learned about the anatomy and the physiology of the adrenal. The present class is on the use of adrenal function tests, which is very important, and the investigation management of adrenal tumors. This is very important for the surgeons. Endocrinology is very interesting in that it's almost like mathematics. The functions are very well laid out. There is very little ambiguity in the process. And we are today fortunate to have Dr. Swati, consultant endocrinologist. She will enlighten us about the adrenal function tests. After that, Pavan will take over and talk about the neoplasms one by one. There is a lot of ground to cover, and I suspect that it will not be done within 1 hour. I think we should stop at 1 hour and put the discussion on the rest of the presentation from Pavan for the next class, rather than hurrying through and finishing. I think it's better that we spend more time. Welcome again, Dr. Swati, and over to you, please.
Again, it has gone on to small screen.
It has gone on to a small screen mode, Dr. Swati. Please put it to full screen, and you can start your presentation, ma'am. Can you hear us?
Dr. Swati? Seems to have lost her. Muted.
Yeah. Ma'am, can you hear us? Perhaps. Ma'am, Pavan, can you please call her? Yeah.
Sorry, can I start now?
Yes, you can, ma'am. I thought we had lost you, but your presentation is in the presenter's mode. Can you bring it to full screen mode? We have lost your screen sharing. Please share your screen again and come to the full screen mode for your presentation, ma'am. Yeah, please go to the full screen mode where now we can see your PPT.
Yeah, I have just gone into the full screen mode one more time.
No,
and
please.
I've swapped it
Now you are on correctly. Please start your presentation.
Yeah. So I will start on this clinical approach to testing of adrenal functions.
Yeah.
So the gathering today is of those of the urologist, and the encounter with an adrenal mass to us can be either of the two ways. Either we seek out the mass or the mass seeks us out. The adrenal mass seeks us out. What do I mean by that is that it is very rare that a patient walks into our clinic, a doctor's clinic, and looking at the patient with the complaints of the patient, we suspect an adrenal pathology, and then we order radiology. That is what I mean by saying that we seek out the mass, which is a rarer scenario. More common, the patient undergoes radiological procedure for any of unrelated complaints which we don't suspect to be an adrenal pathology, and the patient undergoes radiology, and then we find out the adrenal mass, which is truly what we called as incidentalomas. And there can be various reasons, various pretexts why the patient undergoes a radiology. The other way, when we seek out the mass, is generally in scenarios of clinical hypofunctioning or hyperfunctioning of the glands, which is very rare. As is the case in, say, Cushing syndrome, when the patient walks in with the florid symptoms of Cushing syndrome, we do adequate radiological evaluation, and then we suspect adrenal pathology and do a CT scan. It is a comparatively rarer thing. On the other end, and imaging to see whether how the adrenals are. So this is something which is rare. More common is this incidentalomas. So when we talk about incidentalomas, the pathology, the adrenal mass is one of it is largely dictated by whether it is unilateral infections and metastasis and infiltrations and hyperplasias, a completely bilateral. So decision-making factors when we, or should we wait and watch to see whether it is a benign adrenal pathology? And the decision-making factors are decided by one, whether it is looking malignant and the potential to increase in size and spread, or whether it is secretory, whether it is going to harm the patient by means of the hormonal hypersecretion or hyposecretions. And about these secretory parameters for a clinic with an adrenal mass, what do we order as investigations? So that is what I'm going to talk about in next 5 to 10 minutes. So the secretory parameters of adrenal, the way we had learned it during our entrance times is GFR, that is glomerulosa, fasciculata, and reticularis as adrenal cortical layers, and then comes the medulla. So glomerulosa is what the main hormone, the aldosterone, and the job of the aldosterone is aldosterone axis for sodium water balance and maintenance of BP. So the clinical pointers would be patient will be having hypertension. More often than not, it is a young hypertensive patient, difficult to control, requiring 3 or more drugs for controlling hypertension. And very important pointer is diuretic induced, but hypokalemia is present in a patient with adrenal mass, we should always evaluate for the aldosterone axis. And some patients can present, young patients can present with hypokalemic periodic paralysis. Apart from this, there are no peculiar Cons syndrome. The next layer in adrenal cortex is fasciculata, which secretes cortisol. And we all know the functions of glucocorticoids in the body, and the syndrome of hypersecretion of cortisol is what we call as Cushing syndrome. And the clinical features of Cushing syndrome have been evident since its first description several decades back. And just normal people have mooning of the face. But the difference between normal mooning, which is seen in obesity, is what we call plethora, that is reddish hue, which is there. If we ask the patient to show us the photographs from previous times, we can easily see the, appreciate the progression over the period of time in the clinical features. The striae typical of Cushing syndrome are generally these broad, violaceous, what we call as pink colored striae, which are depressed. And the catabolic features of the muscle and the bones. In the muscle, there would be if they are using Indian toilets and all, they will be very much process and vertebral collapse. So these are the features of Cushing syndrome. The next layer is reticular. This is something which is rare. Very present with virilization in female male patients. If rarely we get the adrenal adenomas, which purely secrete pheochromocytomas. And if we dig into the histopathological symptoms, the classical palpitations, which will be sudden in onset and lasting for 5 to 10 minutes with a sense of impending doom, and then it will go away. So if we ask the history, patient may come up with this history in 20 to 30% of the times. Otherwise, generally normal presentation of pheochromocytoma is actually an incidentaloma. So this is my slide for biochemical testing of the three common syndromes, that is Conn's, Cushing's, and pheochromocytoma. So this is the main syndrome, which is aldosterone axis when we do. So generally on whatever antihypertensives the patient is on, as the guidelines recommend, we don't ask the patient to change any antihypertensives, but just one plasma aldosterone level and direct renin concentration. These are the two tests which we need to order for the patient. But there are certain precautions which we need to take, because the normative data with which we can compare the results, those are done in a particular format. That is, what we ask the patient to do while giving this test is that the patient should get up early in the morning, like 7 o'clock, and he should be 2 hours ambulatory. That means the sample is not to be collected in supine position. That is important because renin is a posture sensitive hormone. We change the posture and the renin concentration changes. So this is simply, that is what we need to tell, that patient should get up early, and for 2 hours before giving the sample, the patient should be ambulatory. He shouldn't lie supine. Even at the time of giving the sample, the patient should be seated and shouldn't be lying down. And we have to ensure that patient has normal potassium levels before we send this sample, because if potassium is low, it will cause aldosterone to be falsely low despite patient having Conn's syndrome sometimes. So potassium, ideally on the previous day, we should check the potassium, document it to be normal, and then send the sample for aldosterone and renin, because these are little bit costly tests. Aldosterone and renin in different labs can range from 6,000 to 9,000 rupees. So we should be little cautious about doing the tests, the precautions to be done for that. And the drug adjustment, actually a long list of drug adjustments are there in the guidelines. But if we have a high pre-test probability, like a patient coming with an adrenal mass, we need not do major drug adjustment, just go ahead with renin concentration. If it is suppressed, we can read that readings. We don't have to do the drug adjustment because it is very difficult. These patients are very highly hypertensive. So these are the parameters which we do for Conn's syndrome. Then for Cushing syndrome, ideally we have to do these three. There are a lot of tests in literature, but I have minimized and given the most important tests that need to be done. So actually it is done in 2 steps. In first step, we ask the patient to give a fasting sample for serum cortisol and plasma ACTH. So this serum cortisol and plasma ACTH, there are no guidelines for any posture related. They can be given just like that. This is important because of the patient. Many of the times patients are on exogenous steroids for whatever indications. If the patients are on steroids, then serum cortisol, basal, what we call basal cortisol, will come low. So first step we do on the day 1, we do serum cortisol and plasma ACTH. And after this sample has been given, the same night at 11 p.m., we ask the patient to take 2 tablets of 0.5 milligram of dexamethasone. So this is 1 milligram dexamethasone suppression test. 1 milligram tablet is not available in the market, and that's why we ask the patient to take 2 tablets of 0.5 milligram at 11 p.m. and next day morning between 8 to 9 a.m. in fasting, he should give the sample for cortisol. So this is also levels. The normal value for this is less than 1.8. The cortisol should come less than 1.8. If it is more than 1.8, then we say that it's abnormal and it points towards the possibility of Cushing syndrome. So for a person who has adrenal mass, we do these 3 tests: basal cortisol, basal ACTH, and overnight dexamethasone suppression tests. The other tests which I had listed here, low dose dexamethasone, DHEAS, FSH, LH testo, even if it is not done, these 3 tests are basic minimum that need to be done. And lastly, the pheochromocytoma. Now here, if we read the literature, it's very confusing because there is a long list of tests which are VMA levels and epinephrine, norepinephrine, urinary tests, serum tests. So a lot of tests are there. But what is simple and available to us here is plasma test rather than urinary test, because urinary 24-hour collection has to be ensured. If the patient misses out on 1 or 2 samples to be collected, then the results will be vitiated. Again, it's a costly test. I mean, this test normally costs around 6,000 to 8,000 rupees in different labs. So plasma-free normetanephrine and plasma-free metanephrine is the test which we need to do. The precaution is in as against that for Conn syndrome. For this, patient should be lying down in supine position for half an hour resting, and then while the patient is still lying supine, we collect the sample. This is because metanephrines are metabolites of epinephrine. Epinephrine is the hormone of stress and it is posture sensitive. So it's important to make the patient lie down for half an hour and then take the test. The reason is because several instances we have come across young patients who are referred to us with high metanephrine levels, and when we just repeat the sample by making the patient lying down supine for half an hour, the levels come down to normal. So this is in our routine experience that we had seen that these precautions which I have written here, which the guidelines mention, are actually important. I mean, they do make a difference if not followed for while doing the tests. So, and second thing is when we write plasma-free metanephrines, by general thing, when we order, we just write plasma-free metanephrines, and we expect that the lab will do both. But 90% of the pheochromocytomas, the adrenal masses, they are normetanephrine secreting. That means in 90% of the patients, if you do only plasma-free metanephrines, it will come normal. Unless we specify that we want plasma-free normetanephrine. That if we don't write, the lab will do plasma-free metanephrine because it is fed in their computer system. Plasma-free metanephrine has a different code. Plasma-free normetanephrine has a different code. So plasma-free metanephrines will be normal in 90% of secretory pheochromocytomas who deserve preoperative blocking. And hence, while ordering the test, we have to write plasma-free normetanephrine and metanephrine. So this is all that is important for doing this test. And regarding the values, here the lab specified normative range would work. Only value we have to remember is that of ODS cortisol, dexamethasone suppressed cortisol, 1.8, which we need to take. For all other levels, the lab specified normative range, we are able to read and we are able to interpret them. So here I would like to summarize, like Pavan told me that I have to talk about the adrenal testing. So minimum endocrine evaluation for a patient who is walking up with an adrenal mass are ODS, that is overnight dexamethasone suppressed cortisol levels, plasma-free normetanephrines. The PAC-PRM is plasma aldosterone concentration and renin ratio, and serum electrolytes. So these are something which are very, very minimalistic that we should remember while doing the tests. So here I would like to stop, and I would like to give my comments when Pavan makes his presentation.
Thank you very much, Dr. Swati, for a very lucid and a very clear delineation of what needs to be done. I invite comments or questions from the audience, please. All right, as there are no questions or comments, can I request you to stop sharing your screen, ma'am?
Yeah.
And Pavan can share his screen. Yeah, Pavan, I will be interrupting you and asking you to skip through certain tests, certain slides. Please bear with me. Please go ahead, Pavan.
Okay.
Yeah, we have covered this. Please go through to your subsequent slides.
Ma'am already covered.
Madam has covered. Yeah, please go through again. Keep pushing through. Yeah. Go on, go on. All this is done. Yeah. Go on. Yeah. Please skip through these. All this madam has covered in a very nice way. Yeah. Yeah. Please start from here. Yeah.
Good evening, everyone. I'm Dr. Pavan Kumar, second year DNB resident from Sagar Hospitals. Today, I'm going to discuss on adrenal tumors and its management. Adrenal tumors are classified by WHO as adrenal cortical tumors, adrenal medullary tumors, other adrenal tumors, and extra-adrenal paragangliomas. Adrenal cortical tumors are adrenal cortical adenoma and adrenal cortical carcinoma. Adrenal medullary tumors like benign pheochromocytoma and malignant pheochromocytoma. Other adrenal tumors like adenomatoid tumor, sex-cord stromal tumors, myolipomas, and extra-adrenal paragangliomas like carotid body tumors and jugulotympanic tumor and vagal tumors.
On, please go back. Yeah.
Yes, sir.
If I asked you which would be the one that you see commonly clinically, what would be your answer?
Sir, adenocortical adenoma, sir.
Correct? Say the common ones. I didn't ask for one common tumor. Common
Okay,
ones. Yeah.
Sir, adenocortical adenomas.
Yeah.
And pheochromocytoma, sir.
Yes. Yeah.
And adrenal cortical carcinomas.
Yes. That is quite rare. Secondary tumors are very common. And in the young, in the young, stromal tumors and germ cell tumors are common.
Okay, sir.
Okay, in the young. Okay, but secondary tumors, many times they're bilateral, are something that you have to bear in mind. Yeah, please go on.
Yes. Adenocortical adenoma is a benign tumor of adenocortical cells in which most of the lesions are non-secretory and unilateral. The exact incidence of ACA is not known yet, and it occurs in any age group, including children, and in both the genders. Functional adenomas can differentiate into any of the cortical layers. As I said earlier, excess production of glucocorticoids, androgenic or estrogenic steroids, mineralocorticoids will lead to Cushing's, adenogenital, and Conn's syndrome, respectively. Autonomous cortisol secretion is frequently found in ACA patients, and most of these cases are due to non-ACTH dependent ACS from the adenomas. Functional adenomas produce excess hormone causing various syndromes, but most of the adenomas are non-functional, that is asymptomatic. Small size non-hormone producing ACS are mostly asymptomatic and are diagnosed in CT or MRI, whereas large size non-functional tumors present with symptoms like abdominal discomfort and back pain. The exact cause of adrenal cortical adenomas are unknown. Most of these occurs sporadically and are not inherited. However, it is noticed that sometimes it occurs in people with genetical syndromes like multiple endocrine neoplasia type 1 and familial adenomatous polyposis, under which multiple adenomas and other characteristics are seen. To diagnose ACA, first complete physical examination has to be done and medical history to be noted. Hormone levels in blood and urine has to be evaluated. Adenocortical adenomas usually appear as small, well-defined, homogeneous with low enhanced with contrast medium and can be diagnosed in CT scan. Hence, it is the first choice for the patients with known or suspected adrenal lesions.
Pavan, can you
Yes.
explain each of those things that you mentioned about the CT scan findings? What does well-defined mean?
Sir, well-defined means we can That means the boundaries of this tumor we can
Borders are very
borders of the
clear. It
tumor
is
will be
not
well
diffuse.
Yes,
Diffuse.
sir.
Homogeneous.
Homogeneous means the tumor content is contain same material, like there is no heterogeneity.
Yeah, but what does it mean in terms of your appearance?
So what I mean,
It will look a uniform gray, whatever
Uniform,
that gray is. The Hounslow units, whatever color it is, it will be uniform. Only if you find necrosis or hemorrhage or something like this, it can become heterogeneous, but it's rare, so it's usually homogeneous.
homogeneous.
And low contrast enhancement, what does it mean?
So after giving contrast, so the contrast uptake it is low, sir.
So what does it mean to you? Why is it low?
Uh,
It is not a very vascular tumor.
vascular tumor, yes, sir.
All right. So
Yes.
please, instead of mugging these things up,
No, no, sir.
I'm just saying, if you really understand why this is so, because this is very important, because CT findings are one of the key to differentiating between different types of tumors in the adrenal. So when you look at it, it must be in a very methodical manner. Okay, please carry on.
Yes.
Yeah.
MRI scan, the chemical shift MRI is very popular technique in diagnosing adenomas with greater accuracy, that is around 96 to 100%. Benign adrenal adenomas are usually composed of almost 16% of lipids, which shows measurable differences in the signal intensity. PET scan can distinguish between adrenal lesions and adrenal metastasis, and it has 100% sensitivity and specificity. Functional tumors are managed by medical treatment, whereas non-functional tumors of size less than 4 centimeters should be followed up after 6 months, 12 months, 24 months by imaging and hormonal evaluation. Surgical resection is suggested for non-functional tumors of size more than 4 centimeters and smaller tumors which are increasing in size over time. Unilateral adenomas is managed by unilateral
Pavan, can
adrenalectomy.
I interrupt you?
Yeah, please go ahead, ma'am. Please go ahead. Dr. Swati, please go ahead. Make your comments.
Yeah. So for functioning tumors, Pavan, medical treatment is not indicated. Surgical treatment is the best. Functioning tumors, if a patient is having Cushing's, surgery is the treatment of choice. And if by chance the tumor is not resectable or it is recurrent, then we give medical treatment just for hormonal hypersecretion syndrome. But for any functional tumor, the surgery is the treatment of choice. We don't go for medical treatment. We might give medical treatment as a bridging therapy to prepare the patient for surgery.
Okay.
Ma'am, is that true for all hyperfunctioning tumors?
Yes, sir. As I discussed, all the three layers, whatever hypersecretion syndrome they produced, medical management is not good enough to control the hypercortisolism.
Okay.
And surgery is the straightforward answer, because unilateral adrenalectomy will cause no harm to the patient in future life. I mean, the other adrenal will take care for.
Right.
Even in bilateral tumors, if it is their bilateral pheochromocytomas that we come across in the setting of VHL or MEN1 syndromes, there also bilateral adrenalectomy is what the treatment of choice is, because we can easily replace the hormones later on if the patient needs. So no medical management is good for controlling the hypersecretion effectively, and surgery, adrenalectomy, laparoscopic, retroperitoneal approach, or whatever it is, transperitoneal also, is very straightforward and easy way out for these patients. So secretory tumors are actually an indication for surgery, however small the tumor may be.
Yeah, I was about to say after you finished that there is a controversy in this, because I have seen papers which recommend that once you rule out a malignancy, that you can try medical treatment, which it is not good for a surgeon's ears. I would love to hear from an endocrinologist to say that surgery is the treatment of choice. But there are some papers which suggest that you could try medical treatment for some of these small hyperfunctioning tumors. What is your take on that, ma'am?
So this medical management is only we talk about in subclinical Cushing syndrome.
Okay.
With the rise of CT scanning and radiological imaging, there has been very much increase in the incidence of incidentalomas. And when these incidentalomas in perfectly normal looking patients, when we do adrenal function test, like this ODS cortisol and SETH, we
Okay.
find that they are hyperfunctioning, they are secreting cortisol, but to a subclinical level, to the extent that patient is not frankly Cushingoid, he may be having just hypertension or diabetes as a consequence of that.
Yeah.
And they are truly adenomas, black appearing lesions, rounded, well, small lesions.
Yeah.
So then there is a dilemma whether to subject these patients to surgery or just manage their comorbidities or manage medically the hypercortisolism.
Yeah.
So in that scenario, there is good follow-up data of 5 to 10 years of medical management alone to say that these tumors don't progress and we can manage them conservatively.
Yeah.
But once the patient enters the zone of clinical Cushing's, that means overt Cushing's, then there is no role of medical management. We go ahead with surgery.
Yeah. Very good input, ma'am. Yeah. Thank you. Thank you very much.
Sir, can I come in, sir?
Please.
Sir, even if it is subclinical functioning thing, why should the patient who is either a diabetic because it is secreting, cortisol, or patient is hypertensive, and it also comes with its attendant, end organ damage and things like that, and there is a cause. Why can't still surgery be advised in such people? Because nowadays laparoscopic and retroperitoneal, even it's some people do it in 20-30 minutes. So I think surgery is not such a risk as madam said. I think even for subclinical cases, you may be able to make a case for operating as long as they're functioning tumors. Non-functioning tumors, of course, can be
I agree with you, and I would definitely offer surgery. But I wanted the students to know that there is an option that is being considered by many people, and that is something that has to be discussed with the patient.
Yeah.
That is the important point. Please go ahead, Pavan.
Adrenal incidentaloma is an asymptomatic adrenal mass detected on imaging unsuspected for adrenal diseases. As it is asymptomatic and unsuspicious, it is difficult to diagnose, and management of autonomous cortisol secretion is also difficult. Its incidence is 6% in approximately 87,000 autopsies, and its occurrence increases with age, and with peak incidence is seen in 5th and 6th decades. The cause of adrenal adenomas are variable, and it includes adrenal cortex, adrenal medulla, and metastatic deposits. And adrenal incidentalomas are mostly unilateral. Bilateral adrenal incidentalomas are found only in 10 to 15% of the cases. As per recent studies, most common cause of bilateral AIs are metastasis, primary bilateral macronodular adrenal hyperplasia, and bilateral cortical adenomas.
So, Pavan, I would interfere here one more time.
Yes,
so, the etiology of bilateral masses depends on what series it is, whether it is an autopsy series, whether it is a radiological series. So, back at my parent institute at KEM Hospital, we had done an analysis and published the largest series of 70 patients with bilateral adrenal masses. So because of the referral bias, the most common etiology that we had was actually pheochromocytomas. So in our series, pheochromocytomas followed by tuberculosis was the most common cause for bilateral adrenal masses. Then there were adenomas and lymphomas in our series as a diagnosis.
Okay.
Very nice, ma'am. Please go ahead, Pavan. Yeah.
On gross examination, most of the adenomas are well circumscribed with nodular lesion, and they size up to 2.5 centimeters. Some of the adenomas are encapsulated, and they are yellow to yellow-brown in color. Most of them weighs less than 100 grams, and hormonally active or inactive tumors cannot be differentiated by gross examination. Hemorrhage and necrosis are rarely seen in adrenal incidentalomas. When viewed microscopically, adenomas are composed of cells similar to those of normal cortex, and tumor cells are arranged in small nests and cord-like fashion. The nuclei are small with vacuolated to eosinophilic cytoplasm and small degree of pleomorphism with rare mitotic activity is seen. The differential diagnosis of adrenal adenomas are as shown in the pie chart, where 60% of the adrenal incidentalomas are non-functional and 10% are pheochromocytomas and 9% are myolipomas. There is no exact clinical features of adrenal incidentaloma, but features suggesting adrenal disease may be seen on closer examination. Even functional tumors may not show any significant clinical symptoms. When adrenal mass is large or tumor has significant hormone hypersecretion, specific clinical features may be seen. However, regardless of any symptoms, systemic assessment of functional activity by endocrine biochemical testing to be done. This is the algorithm for the management of adrenal incidentaloma. When we suspect a patient with adrenal incidentaloma, initially we have to undergo hormonal evaluation like 24 hours urine metanephrine and catecholamines and low dose dexamethasone suppression test and PAC bar PRA ratio if patient is hypertensive. If it is a functional adrenal tumor, then we will go for adrenalectomy. If it is not a functional adrenal tumor, then we consider the size of the tumor. If the size of the tumor is less than 3 centimeters, we will tell the patient to 6 months follow up with interval CTs. And if the size of the tumor is more than 5 centimeters, we will suggest adrenalectomy. If the size of the tumor is 3 to 5 centimeters, the following specific factors like young patient, few surgical risk factors, patient preference is to be considered. If case specific factors is considered, then we will go for adrenalectomy. Otherwise, we'll advise the patient for 6 months follow up with interval CT. Hormonal evaluation includes morning and midnight plasma cortisol measurements, 1 milligram overnight dexamethasone suppression test, and 24 hours urinary cortisol excretion.
Can I ask you to skip this, because there are many tests, and Dr. Swati has said the
Yes, sir.
kind of minimum requirements which are quite adequate clinically. So we will remember that and continue with her recommendation. Okay, these are things which can be considered in special situations. Please go to the next slide. Yeah.
Okay, sir. Imaging distinguishes between adrenal adenoma and malignant adrenal masses like metastatic carcinoma, pheochromocytoma, and adrenal cortical carcinomas. Imaging is suggested when size of the tumor in adrenal incidentaloma is more than 1 centimeter to know if the lesion is benign or malignant. Some studies suggest that many of the adrenal tumors detected on imaging were on left side. There are various types of imaging features used for characterizing AI, of which unenhanced CT, also known as non-contrast CT, is recommended as the first-line investigation for all adrenal incidentalomas. In CT, Hounsfield units assessment is the method for the quantifying X-ray absorption of the tissues, and HU measurement should cover at least 2/3 of the circumference of the nodule while avoiding areas of heterogeneity. Assessment of Hounsfield units is for homogeneous regions and heterogeneous regions with variable Hounsfield units. For lesions with more than 10 HU, contrast enhanced washed out CT is the next preferred test, as it is more accurate in characterizing lipid poor adenomas. Washed out CT consists of CT imaging performing before and at 2 time points after the administration of intravenous contrast. Adenomas typically enhance rapidly and slow prompt washout of the contrast. But in the case of malignant adrenal lesions, enhance rapidly with slower washout of the contrast. Dual or multi-energy CT provides additional specific data about the attenuation properties of different materials at different energies. A recent meta-analysis reported that dual energy CT shows comparable sensitivity with non-contrast CT for diagnosis of lipid-rich adenomas. But this analysis was based on the small number of heterogeneous studies. Hence, prospective evaluation on a larger patient cohort is required before its routine clinical use. MRI evaluation of adrenal lesions is mainly used to problem as a diagnostic tool. MRI with chemical shift imaging should be first choice only when CT is not considered, like in case of pregnancy and in children. Chemical shift MRI detects intracellular fat within the lipid-rich adrenal adenomas and differentiated from other lesions. Imaging evaluation has two methods, that is qualitative analysis and quantitative analysis. The two methods, that is qualitative and quantitative methods of image evaluation, assess the change in signal intensity of adrenal lesions between in-phase and out-phase sequence. A recent meta-analysis reported that qualitative and qualitative analysis of adrenal signal intensity index and adrenal to spleen ratio have high accuracy in detecting lipid-rich adenomas.
Pavan,
Yes, sir. Yes, sir.
there is so much stress, and I'm glad that you brought out these points about the various imaging techniques, but there is so much talk about lipid-rich adenoma. Why are you saying that? Why is it important? It goes back to what we said about the need for surgery in incidentalomas.
Yes, sir.
Yeah, I'm giving you a very direct hint.
Sir, I didn't get it, sir.
You know, people are always talking about in all these investigations, they're talking about detecting lipid in the
Yes, sir.
tumor. And you made the point earlier that the adrenal adenoma is lipid rich.
Yes, sir.
15% is fat.
Yes, sir.
So what is the clinical significance of that? You have given the answer earlier. I wanted to know whether you really knew what you were saying. That's
Sir, adrenal myelopoma is another common thing, around 9% in the population.
correct.
Yes, sir.
Correct. So if there isn't fat, what are you concerned about? Hari?
Difficult to distinguish. Not sure.
Malignancy, man.
Okay.
As simple as that. The whole idea of adrenal surgery is only twofold. Rule out malignancy. If you cannot rule out, operate. Make sure that it is not functioning. If it's functioning, particularly as Dr. Sawati said, to a clinically significant level, take it out. So you do not sit on incidentalomas where there is either secretion of clinical importance or suspicion of malignancy. When you say there is a lot of fat, there's a lot of fat. That's what every test is trying to detect. Then you're on stronger ground that it is less likely to be malignant. And you can then, if it is less than 4 centimeters, afford to wait on these incidentalomas. That is the whole point. Okay?
Okay.
All right. Go on, Pan.
FDG PET-CT has high accuracy in characterizing adrenal masses with sensitivity and specificity of around 91%. However, this technique is expensive and less available when compared to CT and MRI. The limitations of PET-CT is adrenal incidentalomas, FDG positive for benign functional adrenal adenomas and non-metastatic pheochromocytomas. FDG PET-CT should be done for patients with suspected solitary adrenal metastasis considered for adrenalectomy to exclude extra-adrenal metastatic disease which are not detected on CT or MRI. So, adrenal venous sampling. The main indications of adrenal venous sampling is primary aldosteronism. It provides lateralization by establishing unilateral aldosterone over-release from small CT or MRI detectable adrenal primary aldosteronism. Although it is a safe procedure when performed by skilled interventional radiologists with low rate of complications, its role is still controversial in other adrenal hormonal disorders like Cushing syndrome and pheochromocytomas.
One sec,
Yes,
Pavan.
sir.
Dr. Swati, I didn't quite understand why the sampling should be more accurate or more useful in aldosteronism as contrasted to Cushing's or Pheo. Do you have any?
Yeah. So generally, sir, pheochromocytomas are unilateral, and radiological features are very characteristic, the CT findings. So we have, the adrenal venous sampling we do only when there is a decision for surgery and we want to be sure which side adrenal to be removed. So mostly in bilateral pathologies we do that. Only in aldosterone secreting tumors is this a problem for us, because in our experience, if we are seeing a clear-cut adenoma on one side and the other side is not atrophic, it is generally hypertrophic adrenals, or there are bilateral adrenal tumors. In those scenarios,
Okay.
now the question is, why aldosterone and why not Pheo and why not cortisol, in which this problem is there. So for cortisol, it is very simple that if one-sided cortisol secreting adenoma is there, other adrenal has to be atrophic. It is not generally hypertrophic, or the other adrenal is thinned out when one-sided adenoma is there. Even the same side, apart from adenoma, the rest of the normal adrenal undergoes atrophy. So that way, the decision for surgery which side to remove is not a problem in cortisol secreting tumors.
All right.
For pheochromocytoma also the same thing. Pheochromocytoma, the radiology is very characteristic, in which we come to know which side is a problem, even in case of bilateral tumors.
Okay. Very nice.
So
Thank you.
for that also we don't have to do adrenal venous sampling.
All right.
And only for cons it is a problem, because the way we can judge the success of surgery by resolution of hypertension is a question mark, because it can be just essential hypertension, and we can't afford to remove wrong side adrenal for con syndrome, because of the obvious reasons. So only in case of, we had done adrenal venous sampling for quite a few number of patients only in case of hyperaldosteronism.
Okay.
And that way it is helpful only in that situation.
Thank you. Thank you.
Sir,
Very
at
much.
a later date, sometime I would like to present our data on con syndrome and pheochromocytoma, especially the radiological characterization.
Sure.
So,
Sure. We can do that, ma'am. Maybe in the next class.
Okay.
We'll do that.
yeah.
Dr.
Go on.
Swati,
I'll come with a better net connectivity.
Yeah.
So
Sure.
we'll do that.
Ravi, go ahead.
yeah, Dr. Swati, the one question was this. You said about the adrenal venous sampling. Does it apply only to bilateral adrenal cortical tumors or even unilateral ones?
I didn't get the question, sir.
Does this adrenal venous sampling that the contrasted between Pheo and other cortical tumors and the aldosteronism? You said that the venous sampling is
No,
useful
sir. Adrenal venous sampling.
Yeah.
Adrenal venous sampling is done only in biochemically proven hyperaldosteronism, just to lateralize the disease, whether it is right-sided or left-sided. It is not done to distinguish whether the hypersecretion is of pheochromocytoma or cortisol or aldosterone.
No, that I understood, madam. But but if there is, for example, if the imaging shows that there is one tumor on one side, then you don't need to do a venous sampling, or you still need to do it.
Yeah. So in hyperaldosteronism, if the patient is young, less than 30 years of age, and if he has clearly very high aldosterone levels, more than 30 ng per dl, and if the patient has hypokalemia, these are the three clinical pointers where we don't go for adrenal venous sampling if a clear-cut adenoma is visible.
Yeah.
Same thing, if a clear-cut adenoma is visible and the patient is 70 years old gentleman, then we are not sure whether that is an incidentaloma, because 70 years old gentleman can anyways have an adrenal adenoma, which can be incidentaloma and non-functioning.
Correct. Correct.
So at a young age, a clear-cut adenoma, hypokalemia, and very high aldosterone levels. So these are the 4 clinical criteria when we let go of adrenal venous sampling and go ahead directly with the surgery.
Correct. No, because I did a lady who had was on some 14 medications, as you said, hypertension was
Yes.
not under control at all, and we
Yes.
didn't do the venous sampling. So, but anyway, the patient now is not on any medication. She's absolutely fine, but she's young,
Yeah.
which is why I think
Yeah.
it was okay. We did a laparoscopic
Yes, yes,
resection, and
yes.
she's fine now. That's why.
Yes, yes, yes.
Go ahead, Pavan. Yeah.
Various complications associated with adrenal venous sampling are adrenal vein rupture, thrombosis, dissection, and intra and periadrenal hematomas. All these can be managed with the conservative approach, and they do not leave any long-term consequences.
All right. I think we will stop here, Pavan,
Yes, sir.
and take it on to the, remember where we have stopped. We'll take the class on to the next session. And Dr. Swati, thank you very much for participating today. And in the next class, we would love to listen to your experience on your series, which you said you will come prepared with. Thank you very much. I would like to leave the session open for questions and comments by the participants, please. Ramakrishna?
Just I was listening. It was very.
Voice is low, sir.
Please go ahead, Ramakrishna. Can't hear you. Some problem with the mic, I think. Kavya?
Sir, no questions, sir.
All right. Ravi?
No, I think most of the questions have been addressed during the talk.
Addressed. All right.
I think, Pavan, I think you presented well. Only thing is, it's a tough topic because I think it's not very common. But all the things that Dr. Swati had outlined, when you were going through the tests and everything, you should have included and skipped some of the things. So that shows that you are actually actively thinking and presenting. So that you need to learn.
Well, to come to Pavan's defense, he didn't know the contents of Dr. Swati's presentation.
Yeah.
That's why I helped him in skipping through some of the slides, which I had, of course, seen earlier.
Okay.
Final comment from our youngest member, Vinod. Is that right? Unmute yourself.
Hello, sir.
Yeah, go on. Can you switch your video on? Let us see you.
Yes.
All right. Backlighting. All right. It's a bit better now. All right. Any comments?
No.
No comments. So you must have learned something. Give me in 3 sentences what you learned this evening.
The clinical test and how to do an adrenal tumor to rule out any differentiating tumors.
All right.
Adrenal gland.
Okay. All right. So what would be the best investigation, radiological investigation in your view?
CT.
Ordinary CT, contrast enhanced CT?
Contrast enhanced.
Contrast enhanced. Maybe right. Yes, that I would agree with that. All right. So thank you again, all of you, for attending this evening's function, this evening's talk. Next time, we will deal with the other tumors. We'll deal with some of the steps of adrenalectomy, some of the things that you need to be aware of when you do an adrenalectomy, the various approaches to adrenalectomy, and of course, Dr. Swati's presentation on her personal series. Okay, thank you and good night.
Sir, I think day after tomorrow is journal club. We had actually postponed it because you were also not there.
All right, I'll be there.
Okay, sir. Thank you.
What? It's Thursday,
Yeah, Friday, Pavan,
Friday, sir.
Friday. All right, I'll be
please
there.
send the paper to sir.
Yeah,
Okay,
yeah.
sir.
I'll be
Thank you,
there.
sir.
Yeah. Okay. Thank you and
Thank
good
you,
night.
Dr. Swati.
All right. I don't know if she could hear us. We thank her again for her very useful inputs. Good night.
Good night, sir.
Good night, sir.